Welcome to Our World in Words and Film podcast, where we explore Parkinson's disease and other movement disorders. I'm your host, Chris Denny. Today we'll be discussing Parkinson's disease and essential tremor, what they are, their symptoms, and how they affect daily life. Joining me is Dr. Homer Ferree, a retired family physician and biology professor at Ivy Tech College of Indiana. Whether you're personally affected by the disease, know someone recently diagnosed, or just want to know more about it, this episode will start you on your journey. Let's dive in. Well, thank you, Dr. Ferree, for joining me today. I sure do appreciate you taking the time to answer a few questions about Parkinson's and essential tremors and movement disorders today.
Right.
I have to say that you were my family physician at one point in time. So,
That's a disclaimer, right?
yeah.
So not a problem. It was an honor and a pleasure.
Thank you.
Okay.
So, well, let's start off. What is Parkinson's? What
All
will
right. That's a good, simple, basic starter. Parkinson's disease is one of any number of what are called movement disorders. Mostly when we think of Parkinson's, we think of tremor, a certain type of tremor, and but there's more to it than just tremor. But it's a fairly well-known disease since an English physician described it 150 years ago. But it also is one that has a lot of secrets still associated with it, its causality and so forth. So we have an understanding of what kind of risk factors enter into the development of Parkinson's, but we also know that it's a disease of older brains, generally people over 60 years of age. And it's something that has an incidence of about 1% uh, in that age group. Now, there are certain people like Michael J. Fox. Like I said, I'm mentioning his name in particular because he's out there in the public. He's very publicly promoting Parkinson's awareness since he suffers from the disease. And most everybody's familiar with him, if not from television, then certainly just his campaign to support the study and treatment of Parkinson's disease. So, like I said, it's one of any number of movement disorders, and that's what creates the difficulty. We need to arrive at an accurate diagnosis in order to know best how to treat it. And certainly, Parkinson's is unique in that category. So, if you want to drill down to the cellular level and so forth, I don't know if you want to do that, Chris. Do you want to talk about
Sure.
what particular neurons? Okay. So, being a disorder of the central nervous system, a movement disorder, it mainly attacks a part of the brain called the substantia nigra, which is in the midbrain area. In other words, that's an area of the brain where there's a lot of intercommunication from the extremities to and from the extremities. Obviously, the muscles are involved. So the neurons of the area called the substantia nigra, in other words, black substance, are just heavily nucleated areas, and they undergo degeneration over time. And we think that it's has like I said, what's called a multifactorial cause. In other words, there are genetic factors that are into it, although only 10 to 15% is truly inherited. But we think there are other gene mutations that cause the degeneration or death of those substantia nigra nuclei of the neurons there. But we know that other factors enter into it as well. For example, what's called chronic traumatic encephalopathy, or TBI, which is traumatic brain injury, such as a boxer like Muhammad Ali. So boxers are prone to it. Certainly, football players are prone to it. But then there's also an environmental aspect to it as well. A lot of different environmental chemicals, including pesticides, but other chemicals as well. And probably things we ingest, all the plastics that we deal with in our lives. I think that probably in the next 5 to 10 years, we'll be able to develop even more detailed causality, uh, and also hopefully open the door to new treatments. So basically, right now we're just treating with things that have to do with the primary neurotransmitter involved. In other words, that chemical that goes from neuron to neuron or nerve cell to nerve cell, and that's been isolated as dopamine. So there are a number of different ways we can either increase the supply of dopamine, mimic it, or replace it. And then there's some other therapies we can get into detail later that have to do with actual surgery, brain surgery, primarily brain, what's called deep brain stimulus. So, like I said, hopefully that gives everyone an idea of what Parkinson's disease is, where it originates, and the fact that it is progressive. And like I said, 1% sounds like a big number, and it is. But hopefully, we won't see any increase as, like I said, we continue to kind of tiptoe around a number of different toxins that are present in our environment and in our diet, et cetera. So, um, like I said, I also we can go ahead if it's on your list of questions. We can talk about how to diagnose it.
Sure.
So,
Yeah.
all right. Well, we'll go right into that. So essentially, Parkinson's tremor, like I said, usually begins around age 60 plus, although occasionally individuals 40 or more will get it. Again, that's called early onset. And the underlying symptom is motor, that is a tremor of some sort. Now, we have plenty of other conditions that cause tremors. The most common is called essential tremor. It's often inherited as a familial thing, somewhere between 20 and 40%, but it's different from Parkinson's tremor in that it's what's called an intention tremor. In other words, uh, if you're trying to hold a piece of paper or a coffee cup or a pen, you're making a intentional effort to do so, and that's when the essential tremor, sometimes called a familial tremor because it is inherited so often, comes in. On the other hand, Parkinson's tremor is typically an at rest tremor. The most common thing, hopefully, you can see my fingers up here, but the most common and obvious symptom is like essential tremor, it's in the hands, but it's at rest. So a lot of individuals will have what's called a pill roll type of motion. Just the thumb, the forefinger, the second finger, and the third fingers are involved in a pill rolling type of motion. So the other thing about Parkinson's, unlike the central tremor or the more benign form of the tremor, is that a lot of times there's stiffness in joints. So an individual with Parkinson's will have a lot of stiffness in their wrist. Okay, they'll even have sometimes kind of a what's called a cogwheeling motion, where they will, actually it's like going through gears. There'll be an incremental stoppage as you, move your joints, and that can occur at the wrist, at the elbow, hips, etc. Uh, Another characteristic of Parkinson's disease is a overall stiffness. So an individual, rather than have a fluid motion and being able to, put your hands and arms, et cetera, through a very fluid, very coordinated, very smooth motion, a lot of times there'll be some stiffness itself where the muscles cause the joints to be stiff. Um, Another situation that we sometimes see, I'm going to go ahead and scoot the camera out. I don't know if you can see it, but a lot of individuals who have Parkinson's will have difficulty getting up and out of a chair. Now, that's true for most of us old folks, older folks than 60 or 65, but it's very, very marked in people with Parkinson's. They will literally have to rock back and forth to generate some momentum in order to be able to stand up. Okay. So now we all do that a certain amount, but what we talk about is a symptom complex. So the more if you have two or more of these characteristics, then you're highly likely to have Parkinson's disease. Unlike a lot of disorders and diseases, there aren't any blood tests that can be done to diagnose it. It's pretty much what's called a clinical diagnosis, although a couple of recent scanning techniques have added to it. But early in the onset of the disease, unfortunately, things like MRI and PET scan can be rather unremarkable. And after Parkinson's been present for 5 to 10 years, certainly those abnormalities in, like I said, the midbrain area, that substantia nigra area of the thalamus will become more apparent. We'll be able to actually see the death and dying of those neurons that are involved. So it's can be a difficult diagnosis to make. Sometimes, like I said, typically if it's a at-rest tremor, involves pill rolling and/or rigidity, and then the tendency to have difficulty getting up out of a chair, changing position. And then people with Parkinson's tend to have sort of a same type of deal where they will begin to almost run. They'll launch themselves into a walk. So that's termed festinating gait. Okay, just kind of hesitant type of gait. So those are all hallmarks. And like I said, if you've got like 5 out of 5 symptoms, then chances are very good that you have Parkinson's disease. And we can even test. We can do a medical test. We can give people a form of dopamine called levodopa and see if people improve. So we can measure a response to a medication and gather some further evidence about Parkinson's disease. So again, as a primary care physician, I made a lot of initial diagnoses, but I always referred them to a neurologist just so that those patients are on the cutting edge of treatment. Uh, Sadly, there's not a lot of new treatments, and some treatments cause a different form of movement disorder called dystonia and dystaxia that are side effects of the medications themselves. Hence, you see, like Michael J. Fox, if you watch him carrying on a conversation, he has a lot of abnormal head and neck movements just due to the side effects of his medication. However, it keeps his symptoms under control. And then I mentioned there's something called deep brain stimulation. It's usually done with electrodes, the little teeny holes burrowed into the skull itself. I mean, I know this sounds grisly, but a burr hole is made and then electrodes are slid in with the patient alert and conscious because the brain itself doesn't perceive pain directly. So that electrode is inserted into an area into that midbrain part of the brain. And while the patient's alert, we can determine as certain areas stimulated, if that's the area that has primary control over the tremor, et cetera. So we can actually, they do some tiny tissue destruction to sort of wipe out that area and remove the tremor impulses. There's also been, it's more for essential tremor than it is for Parkinsonian tremor, but deep ultrasound probes are sometimes helpful with treatment as well. Like I said, kind of run the gamut here of trying to identify what Parkinson's is, in other words, make a diagnosis, what may be causing it, and then some potential treatments. And that includes, like I said, the first line, the gold standard, if you will, is levodopa medication. And then there's something called dopamine agonists, certain drugs, medications. There's a form of an opiate named apomorphone that is sometimes given because it acts as dopamine does. It's just something that simulates dopamine. And then there are enzyme antagonists, something called monoamine oxidase inhibitors that keep dopamine from being broken down. So, that's a third drug. And oftentimes they're used in combination so that you can keep the dose of any one drug at a minimum and therefore avoid side effects, knowing that side effects are more common the higher the dose. So it's not unusual or uncommon at all to treat Parkinson's with two or even three different medications. So, and like I said, we have these other modalities as well in terms of brain stimulation. So I know that's covering a lot of information, but if you want to,
Oh
Chris, we
no, it's great
drill.
information.
Good. So we could drill in on any particular area that might interest you. Um, I guess I might say, unprompted, just discuss things like toxic chemicals, say the insecticides, pesticides that are used sometimes, paraquat, etc. I know there's a lot of emphasis in the legal profession about, suing Monsanto or whoever for producing whatever. But again, most of the time, Parkinson's disease or Parkinson's syndrome seems to be associated with, like I said, not only environmental factors, but also genetic predisposition. In other words, some of us are more predisposed than others just because of our genetic makeup and whether some of those enzyme systems experience mutation which happens. Mutation's a real thing, whether we're talking about infectious disease or whether we're talking about a metabolic process in any given individual's brain. So it's very, very complex, the interactions. And like I said, there's not one single cause, otherwise, we'd have cured it by now.
Right. Uh, I want to go back to essential tremor for a minute and kind of
Sure.
tell the difference to explain the difference a little bit
Okay.
more in depth between the two, because there are some people like Joanne, my wife, who thought she had Parkinson's and turned out that she had
Right.
essential tremor.
I know a lot of people. And, again, essential tremor, what's sometimes called benign essential tremor, or even familial tremor because it's inherited so much. And I happen to be a victim or sufferer of essential tremor myself. I have an older sister that has essential tremor, and it's fascinating too. We know even probably less about the etiology or cause of essential tremor, but basically, uh, if you can see me on camera, you see I do have a little bit of shake
Yeah.
of my hand. Wish I
Yeah.
had a sheet of paper here. Well, let's see. I've got this sock to hold one of the kids' socks. So anytime you try, it's called also, it is a form of an intentional tremor. There are other ones, people with cerebellar disease, people with chronic alcoholism, people with other drug addictions oftentimes have an intentional tremor as well. But if none of those things apply, then, like I said, most likely an individual has what's called an essential tremor. Okay. It's just pre existing, like I said, oftentimes genetic and inherited. And it will come and go. But usually, a person with essential tremor, if they have it on one side, a lot of times they'll get it in the other side fairly quickly. Whereas Parkinson's is a little more of a gradual thing. So, again, with essential tremor, if I put my hand down on a surface, like the top of this table by the laptop, my tremor quits because my hand's at rest. I'm not trying to make an effort to do something voluntary or intentional. And that's where the integration circuits in the brain get messed up. Okay. is just that fine sensation. It's the ability to put your fingertip on your nose tip. Most of the time, I can do that, or to hold a pen in your hand or a pen. A lot of people with essential tremor have a very characteristic writing. Okay, it looks like they've got electrical current going through their hands as they're writing. You probably have seen some people write that way. And the weird thing, I started to say funny. It's not really funny, but there are some mornings that I get up, and I'm sure Joanne does too, that it's worse than at other times. In
Yeah.
other words, I can't hold a coffee cup still. Okay. Certainly can't take a saucer with a coffee cup on it and hold it still. Yet there are other times when it's no problem. Okay. I can drink my coffee one handed. But another clue about essential tremor is you use your other hand or extremity to steady, just like drinking. You'll see a lot of people drink two-handed and they have either an essential tremor or something else similar going on. As far as, things that bring on essential tremor, again, they're fatigue, just being tired. If I don't sleep well at night, almost always I wake up with more of a tremor than I would otherwise. If I take in caffeine, if I drink regular caffeinated coffee, I may get a tremor, okay? More of a tremor than I would have otherwise. If I'm nervous, if I'm anxious, okay, if I'm trying to get ready for a class at Ivy Tech and I'm behind, then my tremor's worse, okay? So far, I'm able to keyboard just fine, okay? I don't have any issues or problems with that. But there are times when I can't even hold a mouse still. Okay. The cursor's all over the place as I'm trying to hold a mouse. The other thing that stimulates that is a low blood sugar. So, being diabetic, and I'm revealing all of this because it's okay. I tell my classes what I'm dealing with every day so they understand that from a physiology standpoint. But when my blood sugar goes low, okay, I also experience more tremor. So there are a number of different things that aggravate an essential tremor, or benign essential tremor, or familial tremor, if you will. And it too is a clinical diagnosis. Like I said, you rule out things that affect the cerebellum, that part of the brain that has to do with coordination, et cetera. And whether it's alcohol, other drugs, trauma. Okay, again, if you sustain a blow to the back of your head and you rack up your cerebellum, so to speak, you can develop an essential tremor from that too, or it's called a cerebellar tremor. But like I said, the essential tremor itself, treatment for it usually involves some kind of a medication that's what's called neuroleptic. Beta blockers are used,
Hmm.
a blood pressure medication that tends to not only slow the heart rate and decrease its contractility, but it also helps to calm impulse firing in the nerves. So things like Inderal, etc., can be used for essential tremor. And then anxiolytics, things like, we don't like to use Xanax because it's such a short acting thing, but longer acting anxiolytics like either Valium or Ativan. Of course, we do aprazolam. We do have to be careful because we could develop an addiction or dependency. Alcohol, small doses of alcohol is oftentimes, that's just been used age after age, as far as having a sip of a wine or a sip of bourbon or something, if you want to quote unquote calm your nerves. Some people use that. I think it's more constructive and less dangerous to use beta blockers to do that. So, and then there are a few specific neuroleptic medications that can be prescribed by either a primary care physician or a neurologist to help manage it. So we have some ways of treating essential tremor as well. Now, because mine is intermittent and generally it's mild, like I said, I don't want to take any medications that will cause any kind of side effects. Now, if this worsens, like my sister has, she not only has it in her hands and arms, but she also has it in her head and neck area. So she will literally have a shaking tremor in her head and her neck. Again, it's an intention tremor because you're trying to keep your head still.
Right.
Okay.
Yeah.
So it has to do with that voluntary intentional movement. I just to give you another interesting example. I was in at the dentist the other day, and they were making a mold for a crown, and I had trouble keeping my teeth clenched on that gooey stuff that they put in to form the mold. I all of a sudden, and it usually doesn't do it, but my jaw, started tremoring. And so I had a hard time keeping my teeth clenched. So it shows that, and again, that was a little stressful situation that brought it out. Okay.
Yeah.
Again, it can be impediment to normal life, what's called activities of daily living or ADLs. But like I said, if I take a few deep breaths or I get up and walk around a little bit and then sit down, it tends to go away, tends to calm. So I'm glad I'm at that non-medication stage of my essential tremor. But some people are troubled with it significantly. And like I said, I feel for my sister because she's got that head and neck tremor. Another thing that essential tremor can affect is our voices. Okay. Now, I love to sing. I sing at church and everything. God bless me with a fairly decent voice. And I love singing, but essential tremor can affect your voice as well. Sometimes it'll affect your lower extremities. It will cause you to be a little unstable. So, again, as we get older, as our brains get older, we are a little more subject to essential tremor. And then again, we may outgrow it a little bit. That brings up another important point for treatment of both Parkinson's and essential tremor, and that is physical therapy and occupational therapy. Those two modalities help us to learn how to manage the tremor better. Okay, sometimes even just taking a dose of Benadryl will help. Okay, so there are times if my tremor gets really bad, I'll take some Benadryl at nighttime. Generally, Benadryl and people over 65 don't mix real well, so I throw that out there with caution. Okay, if you're over 65, sometimes even just something as mild and available as over the counter as Benadryl or diphenhydramine can cause a level of confusion. So, particularly if you're someone who gets up at 2 in the morning for one reason or another, you may or may not want to take Benadryl at night. But like I said, I've never had any issues with it, but that's a medication that can always be tested or tried. So those are the primary differences. And like I said, they're pretty distinct. If you start zeroing in and, like I said, just get the constellation of symptoms over here for Parkinson's and the one for essential tremor over here, then, like I said, they're pretty, you can pretty confidently make a separation after, one or two visits and don't necessarily need to get an MRI or a PET scan, but certainly they offer confirmatory evidence. Now, I think it's at least a screening CT or an MRI is not a bad idea if you're thinking about treating a tremor. You want to make sure it's not due to, say, a tumor back in the cerebellum, okay, in the case of the essential tremor. As certainly tumors can do. It's not just medication or substances like alcohol. So again, I think, yeah, if you've got a good primary care that's interested in neurology or a neurologist, either one I think are very, very helpful with establishing a diagnosis so you know how best to treat it. And like I said, usually in the milder cases, you can use either over-the-counter medications or just undergo some physical and or occupational therapy to help you manage your situation at home. Being able to drink without any problems, being able to button buttons, And all of those things are affected by tremor. So it's not just a nuisance, okay? It's not just a medical curiosity. A lot of people suffer from it. Like I say, if you take 1% of our entire population over the age of 60 and know that 1%, one out of every 100 has Parkinson's, some degree of Parkinson's, that's a pretty high number. So it's, like I said, it's not just a nuisance that we're dealing with.
One other subject I want to cover, and this is from my own experience lately, doing some research and interviews for my website, was the impact of exercise.
Okay.
There's a group called Rocksteady. I don't know if you've heard of it or not. Uh,
Uh, Peripherally, yeah.
okay, Core Sports over in Louisville has a group that of Parkinson's patients that meets over there,
Excellent. Excellent.
and it and I asked the gentleman who runs the program. I said, well, what kind of results do you see from these folks coming each week? And he had made the comment that for some people it works really great, and it really helps them a lot. And then for some it doesn't have nearly the impact as it does on others.
Right, right. And that's just individualization of the disease itself. Like I said, a lot of it depends on the length of time that it's been going on, the rate of progression or degeneration, if you want to look at it, rate of progression of the disease, degeneration of the nervous system itself. Again, certain genetic factors. Okay, um, and then, like I said, a lot of times it comes down to the number of neurons. How many neurons in that substantia nigra of the midbrain are involved? So there are variables, and I think those variables account. Yeah, and we see that with medication too. Just say treatment of hypertension. Some people respond to a certain antihypertensive really well, and maybe not another, and vice versa. So individualization of therapy or treatment is important, but in general, yeah, physical therapy, physical exercise are very good things because they are involved in either retraining our brains, say we undergo a stroke or we develop Parkinsonism, and we get some workarounds. Okay. Most people are familiar with workarounds, but our nervous system is incredibly complex, but it's also capable of making some substitutions in terms of, I would compare it to a blind person, okay, a person who is slowly becoming blind and doesn't have those visual cues to go by in terms of, you know, where to walk, avoid a wall, etc. The auditory system becomes hyper acute. Okay, they suddenly can hear things better than they used to, and that's just amplifying. What that is doing some compensatory amplification. In other words, creating alternative to the sense of vision through the sense of hearing. So you'll talk to people who have gone blind for one reason or another, or even people blind from birth. A lot of times they'll have a heightened sensitivity of their auditory system, or sometimes even what's called the proprioceptive system. That part of our, muscle and nerve interaction that tell our spinal cord exactly, and to a certain extent, our cerebrum, exactly where our feet are in relationship to surfaces, steps, et cetera, et cetera. So again, we're able to compensate for deficiencies in one area with another. So I think that has to do with, yeah, how and why people are able to respond to skilled care, skilled physical therapy, and like I said, be able to compensate for a deficiency. We are truly blessed with a number of different nervous system modalities to give us information about our environment. But like I said, it's been demonstrated that yes, certain senses are heightened or increased because we have a deficit in another area. So, that's important. Walking with a cane, gives us clues about, like I said, where steps are, how far the floor is down, et cetera, et cetera. There's an old, and it sometimes it gets flipped over, something called tertiary syphilis. We don't see it too much anymore, but syphilis is on a comeback here, sadly. But it's a bacterial sexually transmitted infection that causes damage to the nerves. The brain for sure, but mainly the proprioceptive nerves in the feet and the joints, so that literally they lose sensation there. So again, that's where a cane in our hands feeling out in front of us helps. So that's again, those are things that our nervous system is still capable of doing for us, even if we are affected by a certain disease or disorder. And Parkinson's isn't alone in that. Okay.
Alrighty. One last thing.
Sure.
What so what? Well, like in our case, what would you tell somebody if they suspect Parkinson's or essential tremors or think they might be experiencing something like that? What would your best
Okay.
advice for them?
So what I would recommend is, as a physician, as a generalist or a family physician who's kind of interested in and has seen and treated a number of different illnesses, and like I said, to me, that was part of the reason for becoming a family doc, because I didn't want to get bored with one thing, and I'm constantly on the lookout for things. But I think any significant loss of function is your driving force behind seeking an accurate diagnosis and early treatment. So that's the first thing I would tell someone. If you are losing function, if all of a sudden, like I said, you can't write your name without it being that electrified signature, if you can't go up and down steps with losing your balance, if you can't hold a cup of coffee, okay, to drink, um, so that's the point at which I think you need, to find out exactly what you're dealing with so that you can both take some preventive measures if they're available to you, and it varies with the disorder, but also undergo first line treatment. Okay. Now, if you develop, say, an essential tremor, you don't want to go over and see a neurologist over at U of L and get an ultrasound probe placed in your brain. No, that any of those aggressive measures are basically for people who either don't respond to medication or the medication causes them side effects. Okay. So I think there's, again, I would just use a loss of function that you had previously. Okay.
All right.
So, you shouldn't be worried about going and hitting a ball at a 50% rate if you've never been able to do that before. Okay. But if something that you commonly did is impaired. Okay. So if there's a loss of function, that's the point at which I think you need to be a little more aggressive in terms of getting diagnosed, accurately diagnosed, and treated most effectively. Plus, we have new treatments coming, forward all the time. I know there's stem cells, clonal stem cells that are often used. That's being experimented right now with replacing some of these, the substantia nigra neurons. So, cell transplants, stem cell transplants, etc. Okay. And by this time, by the way, it shouldn't be a religious or philosophical objection, because we have all kinds of stem cell lines. I know every time I delivered a baby, I drew cord blood, and blood from the cord, because it had a lot of the fetal blood cells. A lot of them are
Right.
stem cells. We sent
Yeah.
it over to U of L. They separated out cell lines and so forth and so on. So these things have been developed over generations. So a philosophical or religious objection shouldn't really apply, because we're not harvesting cells from individuals, say in terms of a elective abortion or whatever. We've got enough stem cells that we can do research and do treatment, et cetera, et cetera. But that's what's coming. I love to talk with my students up at Ivy Tech, whether I'm teaching anatomy and physiology or whether I'm teaching infectious disease, or microbiology. I love teaching with them what's happened in the last 5 years and what is likely to happen in the next 5 years. Okay, provided we get adequate funding and support for universities and so forth to conduct this research. But I think it's kind of exciting. I think in the next perhaps 5 to 10 years, we will actually have more effective Parkinson's disease therapy. I don't know that we'll have a cure, quote unquote, but we'll see. And then the same thing with essential tremor, better ways of treating that, since they're common disorders, common diseases. So yeah, if you have a 1% incidence of something, that's pretty common. Okay. So I think it warrants further study and treatment, type of modalities. So yeah, I think it's like I said, you don't want to necessarily ignore something and just think, that's just getting old. That's, as my mom used to say, old timers disease. Okay,
Right.
so
Yeah.
a lot of things are old timers disease, but here I am, just having turned 70, and I don't really consider myself an old timer yet, because even though I've got this essential tremor and I have diabetes, hey, I got a lot of other things going for me, and I enjoy teaching, and I enjoy training the next generation, and I enjoy participating in this kind of interaction with you. Okay, Chris?
All right. All right. Thanks, sir. Thank Dr. Homer Ferree. Thank you for joining me today. You've been a big help, and I
Right.
hope people um, get something out of this information and learn more about the diseases and treatments and that are available.
All right. That's the goal. Okay. You
Thanks,
take good
sir.
care, Chris, and say hi to Joanne.
All righty.
All right. Bye-bye.
Well, that concludes this episode of Our World in Words and Film podcast. I hope today's discussion brought some insight into Parkinson's disease and essential tremor and their impact on a person's daily life. A big thank you to Dr. Homer Ferree for sharing his expertise and insights, and to our listeners, whether you're personally affected, know someone who is, or are just beginning to learn, we appreciate you joining us on this journey. The music for this podcast is titled Open Arms, composed by Adam Drake and Tom Jenkins. This title and more can be found on audionetwork.com. Until next time, take care and stay informed.